Hello and welcome to the Director's Desk, the podcast where we highlight the groundbreaking work of the National Institutes of Health and the exceptional people advancing biomedical research in public health. I'm Dr. Bhattacharya, the director of the NIH. Today's episode is an important one. We'll be discussing the newly released HHS final review, Treatment for Pediatric Gender Dysphoria, Review of Evidence and Best Practices. This comprehensive review, along with its peer review supplement, reflect months of rigorous analysis and collaboration across the Department of Health and Human Services. To help unpack the findings, I'm joined by several contributors for the review. Each brings unique expertise and perspective to this complex and evolving area of clinical science. I'll invite them to introduce themselves one by one.
Hi, I'm Farr Curlin.
I'm Farr Curlin. I'm a physician and professor at Duke University. I practice palliative medicine, and I'm in the bioethics world as one of my hats. Glad to be here.
Nice to meet you, Farr, and thanks for coming out.
Hi, my name is Evgenia Abbruzzese, and I'm a co-founder of the Society for Evidence-Based Gender Medicine.
Delighted to meet you too.
Hi, I'm Ray Yuan Zhang. I'm a Canadian researcher. I have done systematic evidence review and guideline to support the guideline development process.
Your work was very important in the report, I can tell, because that's the evaluation of the guidelines are such an important part. We'll talk about that.
Thank you.
Yeah. Hey, my name's Kristopher Kaliebe. I'm a psychiatrist and professor at the University of South Florida, and I'm a child psychiatrist, really at heart, clinician educator. I also do forensic work, so I testify in court and I treat kids with gender dysphoria.
Nice to meet you, Chris.
Yeah.
My name is Alex Byre, and I'm a professor of philosophy at MIT.
Nice to meet you, Alex. We get to talk about how philosophy matters for this.
Of course.
Because it does.
Hi, my name is Moti Gorin, and I'm a bioethicist and philosopher at Colorado State University.
Nice to meet you, Moti.
I'm Lior Sapir, Senior Fellow at the Manhattan Institute for Policy Research. My work deals with the intersection between evidence-based medicine and public policy.
I'd say nice to meet you. We already know each other, Lior, but thanks for coming out.
Hi, I'm Kathleen McDevitt. I'm a psychiatrist. I work at Baylor College of Medicine.
Nice to meet you too. So thank you all for coming out to we're sitting at the NIH in a fancy building. So, but it's a pleasure and it's difficult to actually get into the building. There's crazy security. And so all of the folks here not only had to work on the report, but they also had to somehow navigate NIH security. So thank you for coming out. Why don't we just dive into this? So first, why don't we start with just some basic questions? So what is the report and why is it coming out now? And you all should just start chiming in. I think calling on people sounds like fourth grade. So
this is a report about pediatric medical transition. So specifically, it looks at questions about the use of puberty-blocking drugs, cross-sex hormones, and surgeries to treat a condition known as gender dysphoria or gender incongruence in minors. The report was written pursuant to an executive order that the president signed on January 28th that instructed the Department of Health and Human Services to produce a report on evidence and best practices on this topic within 90 days. And so the initial report was published in May. There was a extensive peer review process that was planned from the beginning that would start right after publication of that initial report. And on November 19th, the final version, the peer-reviewed version, with all of our responses to the peer reviews, was published. So that's kind of just in a nutshell.
So, Leo, can we unpack this for just a bit and for other folks to chime in? So the topic is gender dysphoria, right? So specifically in kids, not in adults. Gender dysphoria means, if I'm understanding this correctly, and I'm not a psychiatrist, so please correct me, that the self-identification of someone's sex is different from their actual sex, right? So if they're a boy, they think they're a girl. If they're a girl, they think they're a boy. That's it. Did I get this wrong?
I don't think I think part of the issue here is the lack of clear definitions of what the phenomenon that we're talking about is. And actually, Alex probably is in a better position to talk a bit about it, but gender dysphoria is a condition that originally was defined as distress associated with sort of the feeling that you're describing. So there's a really clear sense that the young person is distressed or functionally impaired, and that is what made it a diagnosis. But by now, this has become essentially redefined to a situation where distress is not needed, but whether, and it's just a person's identity. But the person doesn't need to be confused about their sex. They could be very aware of what their sex is and still be diagnosed. So the whole issue of the diagnosis is something we really need to unpack because everything is downstream from it.
So the key thing then is not what I said earlier about the confusion about the sex, but the distress that comes with that. That's the DSM-4, whatever DSM-5 diagnosis.
Yeah.
Right? Yeah.
That was the basis for the current treatment models. The target of treatment was the resolution of distress. That's how it became a branch of medicine. However, in 2025, and actually now for a few years, we're operating on a new model of gender incongruence, which doesn't require any distress.
So that's closer to what I said. Right.
But it doesn't require confusion
doesn't
either.
require confusion either. Okay.
It just requires the desire to undergo medical treatment.
Maybe we should just draw a sharp distinction between having gender dysphoria on the one hand, which, if you go by the latest 5th edition of the DSM, the Diagnostic and Statistical Manual, that distress is an essential component, which is what you might expect, because, of course, it's supposed to be a condition that requires medical intervention. Draw a distinction between having gender dysphoria and being transgender. The two are just very, very different. So being transgender is not a condition that requires any medical treatment. You can be transgender and not have gender dysphoria. You can also have gender dysphoria and not be transgender or identify as transgender. And indeed, historically, the early onset cases of gender dysphoria typically resolved with time. So the person would just grow up to be content with their sexed body and not desire any medical intervention.
So like a tomboy,
yes,
girl
exactly,
who
yes.
plays with cars or something, or plays baseball or something. I mean, that would be, that was a pretty typical thing. And when I was a kid, or boys who were a little more feminine in the kinds of interests, whatever that means. That's not what we're talking about.
No, that's not what we're talking about. But there is a connection between being gender non-conforming as a child and having gender dysphoria, in that typically, historically, the females with gender dysphoria exhibited tomboy-like behavior. It's not that they were only tomboys. Tomboys combined with distress at their sexed bodies, essentially.
So how did that notion of kids, boys wanting to play with dolls or girls wanting to play softball or with trucks or whatever, how did that notion, which is completely innocent to me, I have 3 kids of my own, boys and girls both, how did that become medicalized? That as I was reading the report, I was struck by the focus, of course, on how the healthcare system treats that. But the healthcare system didn't always treat that as something to worry about, or certainly something that's not of such public concern that it warrants an HHS report. How did that happen?
So I don't think it's a straight line, and I think it's a bit circular, actually. So originally, nobody was thinking about medicalizing children. The entire field became a field around the question of how to help mature adults. So there have been very gender nonconforming mature adults who have had a strong wish to present as members of the opposite sex for a long time, before estrogen and testosterone were even synthesized into drugs. There were people that would use clothing and modify their appearance and act in stereotypical ways that are more stereotypical for the other sex. And so in Germany, there was a very well-known physician and really famous public figure whose name is Magnus Hirschfeld, who was one of the pioneers of gay rights movement. And he began to study the population of people who he called them he is the one who kind of coined the term the third sex. And he said, so there are stereotypical men who behave in a very masculine way, stereotypical women that behave in a feminine way. And then there is this third sex. And at that time, he lumped into the third sex gay men, lesbians, feminists, and wrote a book about the third sex. And he had great admiration for the third sex. He said there are a lot of them that are really, especially feminists, were really pushing progress.
So this is different than the idea that either you produce ovaries or you produce male gametes. I mean that's binary. This is distinct then from that notion, that strictly biological notion. This is more.
Yeah, he thought of it as a kind of a social phenomenon, although he hypothesized that in the future science will be able to scan the brains and analyze. There's a lot of hope and belief, and there's a clear hypothesis that there is something physically really different about these people. We just don't know what it is, but now we need to help improve their quality of life, reduce their suffering. And there were, in fact, people that were badly suffering. And so for some of the people who really wanted to present as the opposite sex, he began to develop treatment approaches for them.
But that was for adults.
That was for adults. And so adults were treated then for several decades, and it was a fairly rare phenomenon. And but it became more and more common the more stories were written about such adults. And there was in the report we talk about a really important case of Christian Jorgensen, who was an American with European roots, who went to Europe, underwent medical transition, and came back and became a celebrity of sorts. And because nearly every paper wrote about Christine Jorgensen, who was born George and became Christine, suddenly, within weeks of that publication going viral around the world, more and more adults began to approach doctors and saying, well, I'm just like that. And actually, there are many varied presentations, but everybody really saw Christine as their symbol and said, well, I'd like to do that too.
What's the time frame? That was
1950s. And so that then really launched gender medicine as a field for adults. And through various happenstance, the Netherlands began to offer national coverage for gender transitions. They were the first country to offer national insurance coverage. And as a result, they got the biggest sample together that they could systematically follow. And it is when they analyzed the adult outcomes and they saw that the adults were not getting better like they thought post-transition, that the idea was born.
Can I stop you there and ask you a question? Maybe all other folks want to step in. What does it mean to get better in this context? Because that's not an obvious question, right? So you have this, we just have that conversation about what gender dysphoria, confusion and all that. And I assume that there's also psychological distress that sometimes goes along with this. What does it mean for someone to get better in this context?
I can tell you how originally it was thought, and then I'll give the mic to somebody else. So when the Dutch researchers did this first analysis, and they really hoped that the adults would get better, what they were, there was actually a lot of thought that went into, well, actually, what does this mean? And there was a debate. Should there be objective outcomes, such as reduced depression, reduced anxiety, reduced suicide attempts, or should it be subjective measures such as happiness? And they measured both sets of outcomes. They found there was no objective improvement. People who were struggling with functioning in life were still continuing to struggle. But they emphasized the subjective results because they said, well, since the condition itself is subjective, then the outcomes should also be subjective. But even in that, with that framework, they couldn't really find positive outcomes. They said the outcomes were really mixed. Some people reported being happier, but objectively, they were in not in a good state.
Were there fewer suicides?
There were no fewer suicides. They struggled to maintain relationships, build families. They struggled with suicidality, ongoing suicidality. So the measures...
Suicidality means you're contemplating suicide, that not you're carrying.
There was both. They also had high rate of post-transition suicide that they found. And they concluded that transition is not a panacea. Some people report feeling good about their decision, but objectively they could not find any improvement in functioning.
But how do you go from that largely dispiriting kind of result from the transition to, well, let's extend this to kids? Like if we've tried it in adults, it doesn't seem to provide objective evidence of improvement. How do you then say, well, let's extend this treatment to children?
So that was the very hypothesis, is that we're getting to them too late. The bodies are already masculinized or feminized too much. So these people, yes, you can give estrogen or testosterone, but it doesn't do enough. They're still not passing. So it must be that we got to them too late. Let's do early intervention.
So passing was one rationale, and another was that going through what today is sometimes called the wrong puberty was a very distressing experience that left these psychological scars for a long time. And so this was one of these rare areas of medicine where the failure of treatment, at least according to the people who proposed the protocol, the failure of treatment in adults breeds an experiment to do it, or not even an experiment, but a desire to start earlier in children.
Right. Before we head on to the next set of topics, I wanted to. We've been talking about this in a kind of language, and the report has a very fascinating chapter on the language used to talk about this. If I'm a novice to this field, I use the terms. If I ever use the terms, I use terms like gender affirming care because that's what all my colleagues in the medical school were using. Just listen to that term, gender affirming care, right? Meaning that the sex that the child thinks they should be getting medical affirming care. So they should be getting care. That means medical treatment that affirms that notion of what sex they think they are, right? And that's the neutral term used to describe this care, right? In medical settings, gender affirming care. There are other terms like gender identity. And actually, broaden this out. There's a movie with the title "What is a Woman?" Right. So this is all connected, I think, in some sense, to this sort of like social conversation we've been having about what does it mean to be a woman or a man or third sex or whatnot. There are other terms which sound like euphemisms to me. Chest surgery or top surgery in place of mastectomy. Bottom surgery in place of vaginoplasty, people instead of children, retransitioning in place of detransitioning. These are all listed in the report. Sex assigned at birth. But I mean, that's one of those. Orwell says, whenever someone's using the passive voice, they're trying to put something over on you. Sex assigned. Who's doing the assigning, right? So, Can someone tell me about this language, like this language problem? It seems like the reason I call it a problem is because if you think about it as language is supposed to describe the thing that's happening cleanly, so you can make informed, clean decisions based on your own values. Well, the language that we are essentially been using about this leads you to a particular conclusion. So why is that language conversation in the report, and why is that so important?
Well, this is one of the reasons why gender medicine is such a unique field. I mean, medicine, as you obviously know, is full of its own proprietary jargon, like bradycardia or hypertension or something. No doubt you could continue the list for many hundreds of words. But these words are not euphemisms, and they have relatively clear meanings. Sometimes they're introduced precisely because we need a word to make some important distinction. But gender medicine is full of words that are either euphemisms, like top surgery or sex assigned at birth, or else they're extremely obscure, like gender identity, which is a foundational notion, really, in this area of medicine, at least to go by the way many gender-affirming clinicians.
So, Alex, how is that term obscure?
Well, it's interesting because it was not at all obscure when it was first introduced by two psychiatrists, Robert Stoller and Ralph Greenson in the 1960s. When it was introduced by them, it just meant the conviction that you're one sex or another. And this is a very important notion because it is actually a cognitive milestone when you're growing up. At some point, children realize or come to the conviction that they are either male boys or female girls. But later, the meaning of the term changed. And now, if you look at the official definition in, for example, WPATH, the World Professional Association for Transgender Health's latest standards of care, they always have glossaries in these things. And it's just extremely unclear what the phrase is supposed to mean. All we know is that supposedly gender identity, whatever it is, can be either aligned or misaligned with your sex assigned at birth. And if it's misaligned, then you are transgender. And sometimes, although certainly not always, sometimes this misalignment causes gender dysphoria. But if you look at the way the term is actually defined, it's typically defined using the word gender. So one's gender identity is one's internal sense of one's own gender. But then if you ask, well, what does that mean exactly? It clearly doesn't mean sex in this context. There is no satisfactory answer to that. And of course, I'm sure you know this better than anyone. Patients deserve clear and straightforward communication from their doctors. I mean, obviously, you need to be sensitive to the patient's concerns, but describing their condition in extremely obscure verbiage or using very misleading euphemisms like sex assigned at birth, which sort of suggests that your sex is a somewhat arbitrary decision, which perhaps could have gone the other way, made at birth by some pediatric authority figure. It's just very misleading.
Just to add something short to that, it's not just that it's obscure. It's that when you finally get an answer to what is gender in the term gender identity, it's stereotypes. And this goes back to the tomboys who like to play with trucks. I mean, even if you look at the DSM's criteria for diagnosing gender dysphoria, it's almost all based on stereotypes, nonconformity to stereotypes. And this, of course, is a problem. It's a problem for the field. It's a problem for the field's effort to present itself as a kind of a progressive cause. And it's especially a problem when you're dealing with teenagers who sometimes struggle to fit in with expectations about their sex. And so yesterday's tomboy is today's trans boy. And if that didn't have medical implications, we would all just shrug our shoulders and not care. But tomboys were not getting medicalized. Trans boys are.
That's one thing that struck me about the language, right? It's, in one sense, it's medicalized, but in another sense, it's moving away from neutral medical descriptions of things. It's a mixture of both, all seeming to put people in a place, put families, kids in a place where the idea is there's something wrong with them. There has to be something done about it, and that the medical care system can do something about it. Actually, I'd love to have a conversation now about how does that work, right? So, I had 3 kids, and I watched them grow up, and now they're out of the house. But I can imagine a child of mine getting very distressed about their identity. In many ways, that's what growing up and going through the childhood and adolescence is discovering who you are. How does a kid go from that to entering sort of the medical care system where they end up with puberty blocking, cross-sex hormone, so on? Like, what's the process?
Yeah. Well, I can answer that in different ways. I could say, what is the process in a situation where there's a gender clinic who's going to pull them in and put them on a pathway towards, affirmation and medicalization? Or what is the process when you come to a clinician who is more a standard, let's say, mental health professional who would understand that kids go through phases, that they have distress that has all sorts of meanings, that, there's sort of a metaphorical piece to this. There's a issue about gender nonconformity and same-sex attraction, stigma for that, internalized, externalized. Whenever you have a child in front of you, in theory, you should be individually looking at them, trying to understand the context of their life, trying to make sense of the distress. And I don't think under normal circumstances, it would come into any clinician's mind, oh, we need to go to a medicalized intervention for this type of distress. However, because these treatments have been entered into the lexicon as the established treatment for this by, gender clinics and by, the World Professional Association for Transgender Health. Now clinicians are being trained, go along with the narrative of the kid, figure out whether through some assessment, which could be a significant assessment, or just really letting the child lead, and then to medicalization. So there's not one way, there's many ways this is handled, but it seems to me any route towards automatic affirmation or puberty blockers is a deviation from normal ethical care. And that's kind of what drew me into this, because I see patients and I have to figure out what to do with them. And I also train residents and child psychiatry fellows, and I have to be able to teach them what is ethical, proper care. So here we are, hopefully writing some, over-enthusiastic, overly strong recommendations that have kind of proliferated our society, and now we have to undo some of that.
So we're going to talk a lot about ethics. I hope actually, why don't we just do that while we're here? I think a premise for the ethics is that the evidence that the treatments being offered is not particularly good, that it's going to help, or that there's not evidence that there's evidence that they might hurt. Then so that evidence, of course, contributes to the ethics of the ethical discussion. But let's just, for the ethical discussion and for the now, let's just take it as a given. We'll talk a lot more about this in a bit. That the scientific evidence does not support the idea that that these treatments, this pediatric transition, medical transition kind of treatment helps in, and we can debate about what helps means again, but like it does. Let's just take that as a given. Normally in medicine, if you are going to recommend a treatment, you need to have evidence that it helps. And certainly you have to have some idea that it's not, that there isn't a possibility of it hurting. There's some things, like in cancer, for instance, you give treatments that you are sure are likely to hurt, but with a substantial chance it's going to help, right? So it's not that you never do things that aren't risky, but the things you do are commensurate with the situation the patient finds themselves in, right? And when a doctor tells a patient, or a parent in this case, that if you don't do this, your child might commit suicide, right? That's a big deal. Because now the parent is put in a position where they have to decide, what are they going to do for their child? Like, are they going to do something as extraordinary as block their puberty, right? Not let them go through the normal process. What is that like? What does that look like from the point of view of a parent? What does that look like from the point of view of a child? How do those interactions actually work?
Well, we started with, in terms of thinking about the ethics, we started with the observation that you just sort of articulated, which is that we're offering extraordinary interventions to children with no physical pathology. So arresting puberty, prescribing cross-sex hormones in some cases, surgeries as well. And as you say, anywhere else in medicine, if you're going to be prescribing any intervention has risks. There has to be some kind of proportionate. You have to have good reason to believe there's a proportionate benefit, so that the net balance is benefit over harm. And we'll talk, I think, soon about the state of the evidence. But that's right. The evidence that we have for benefit of these interventions is very, very weak. That's been revealed by multiple systematic reviews. and the harms are far more certain. So if you just do your standard kind of risk-benefit analysis that we do, the FDA does when they're approving a drug or not approving a drug, and if you apply that kind of standard analysis to so-called gender-affirming care, it just turns out that the risk-benefit ratio is negative, very negative, in fact.
But if that's the case, how did we get in a situation where medical societies and doctors at scale decided that the opposite was true, right? I mean, it's like was it a failure of ethics or failure to read evidence? What led to this sort of situation we find ourselves in?
If I can jump in, so I think the realization that the evidence has not shown any benefits or any reliable benefits is actually quite new. Finland was the first country to conduct a systematic review in 2019 and to say we see no credible evidence of benefits.
Okay, I think you're right about that. But then the question is before that.
So what I was going to get to that.
Okay.
But I'm just acknowledging that this recognition that there's no evidence is actually quite new. If you think 5 years is recent, that's actually just in the last 5 years. The practice of youth transitions was launched based on the basis of a pair of studies from the Netherlands that became widely promoted in the medical community as gold standard, amazing high-quality studies that proved tremendous benefits. And these are the Dutch studies. It's become known as the Dutch protocol. And the entire medical establishment in the Western world accepted that pair of studies as the basis and built the entire branch of medicine based on those studies. It took several years for us to take a close look at those studies. And what we discovered is that it is not unlike the Porter and Jig study that started the opioid crisis. The studies weren't closely read. Once we read those studies closely, we saw that there is no credible evidence of benefits and that the harms in those studies were essentially hidden in plain sight. For example, one child died as a direct consequence of early puberty blockade because during surgery, that a complication they would not have had if their puberty hadn't been blocked. 3 children developed severe diabetes and obesity in the period of being treated with cross-sex hormones. At least 1 discontinued treatment in the midst of it. Several disappeared from follow-up. And that's just for 70 kids who were only attempted to be followed for a few years. And so once we reread those studies, that is essentially when a lot of us began to focus on this area. Once we realized that the entire branch of medicine and tens of thousands of children were being treated on the basis of a pair of very, very flawed studies.
That's shocking and very, very interesting. But I just want to note that this is not unique in the history of medicine. Like that there are these examples of just tremendous reversals from based on very scanty evidence, like lobotomy, frontal lobotomies comes to mind, or the more benign. It's like how you treat ulcers. The discovery that that they're actually caused by bacteria changed how we treat ulcers. That kind of reversal makes sense. This is of a different kind, right? This is that a small amount of evidence. 100 kids, I think, was the original study, right? The Dutch studies, something like that.
70 kids.
70 kids.
That dropped to 55.
55. That small amount of evidence then led to a whole field adopting the conclusions from a study that should have been followed up with more replication, more analysis. And it's interesting that didn't happen, right?
Perhaps it's worth quickly noting that of the 70, the overwhelming majority were same-sex attracted.
All but 2, I think.
Yeah, all but right. That's right.
Right. I mean, there's a sense that this medicalization of being gay.
Well,
right?
exactly.
That's kind of that's hung over this field, right?
And that's one of the ironies of when gender medicine advocates criticize people like us for scrutinizing the science, and they say things like they're anti-LGBT. One of the ironies is that if you just look at historically what the research has shown about how these kids, especially the prepubertal children, develop beyond adolescence, most of them turn out to be gay. And so there's a real concern in the field that this is, kind of a new form of gay conversion therapy that's using hormones and surgeries. I did just want to address one thing that because you did ask about the medical societies, the medical associations, and we get into that quite a bit in this report. And I think it's a really important part of the story. Why is it? Because, in the United States, when advocates want to say that these treatments are well supported, they don't point to systematic reviews, which is what they should be doing if they're following principles of evidence-based medicine. They point to consensus statements. They point to medical society policy position papers or guidelines. And of course, the question is, are those statements, are those policies and guidelines based on systematic reviews? And the answer is categorically they are not. But so the question is, why do they continue to support the practice, or at least oppose any restrictions on it? And it's a long and complicated answer, and I won't get into it here. But the bottom line is, a lot of these medical societies have specialized committees that were tasked with looking into this area of medicine. And those committees naturally attract people who are very ideologically aligned with the project, or who, in good faith, kind of innocently think that this is good science. Maybe they don't read the studies that closely. The broken chain of trust in medicine is a very, very important explanatory factor behind why we are where we are. There was recently a really good example of the American Medical Association, where we saw the video of the president of the AMA basically say, look, I defer to the gender clinicians because they're the experts. But the gender clinician that he said he defers to turns out to not just not know the area of research, not even to know how evidence-based medicine principles actually work. So this is that broken chain of trust that I think is the most important explanation for why the medical societies have dug their heels in on this issue.
Okay, so this is a good time then to turn to the evaluation of the evidence that's in the report. So why don't we start with just something very, very basic, because you use the term evidence-based medicine. What does evidence-based medicine mean? Why is it the right way to evaluate the totality of evidence on a topic?
Yes. So thank you for this question about evidence-based medicine. According to the principle of evidence-based medicine, we need to make a medical decision based on the best available evidence. And health professionals and general public, they may heard many, many times saying like, there is a new, very nice study prove that hormone therapy could save lives or lower risk of suicide. And this is the evidence that so-called gender-affirming care is working or is beneficial. But actually, in what we call in best available evidence in evidence-based medicine, we need to systematically collect and appraise the evidence or the studies to answer this question. And so there is general rule is like systematic evidence review is preferable or is better than individual cherry-picking studies. And then they are better than personal experience by individual doctors' opinions. So we need to do systematic evidence review to figure out.
So I used to teach a class at Stanford about this sort of thing. So like my memories are vague of this, but like randomized trials were at the top, then like rigorous observational studies that are careful to not confuse correlation and causation. And then way at the bottom is like, case reports or something, right? So, is that the standard you use to evaluate the evidence in this report that you all wrote?
In this report, what we have done is an overview of systematic reviews, or some people will call umbrella review.
An umbrella review?
Yes.
Okay, so that's a new term. What is it for me? What does that mean?
So that means we go to the literature and medical databases and search and identify that existing systematic reviews that have been launched to assess the benefits and the harms of the so-called gender-affirming cares. And our unit of analysis is the systematic reviews, because we know there are existing reviews and evaluations to answer the questions.
So right. So it's not. So the pyramid we talked about, randomized trials at the top. You're saying what you've done is you've said, look, I think you got 17. There's 17 different groups have done reviews of the literature. Sometimes they come to different conclusions from each other. about some of the. I'll ask some of the substantive questions just a bit. We'll do a lightning round on what people think about them. But the idea is that the idea of the report is that you're trying to synthesize other people's synthesis of the evidence on this, because there's just a vast literature. Like anyone who wants to go dig into it can go to search the literature on PubMed and try to find it, and you'll find thousands and thousands of studies, right? So what do those 17 systematic reviews say, and how did you go about reconciling those 17?
So one important consideration in evidence evaluation is the strength of evidence or certainty of evidence. That said, we need to consider the limitations and the strengths in the systematic review process. So when we identify 17 systematic reviews to answer these research questions, we also use a structured tool to assess their methodology process. And from all these 17, we identified high quality systematic reviews. By high quality, we don't mean they are perfect, but their methodology process is acceptable and they are trustworthy. And from there, what we need to do in evidence review is to summarize what the evidence says about benefits, what the evidence says about harms. But also on top of that, we need to answer another important question is how certain we are about the evidence. So based on the 17 systematic reviews, we select the high quality systematic reviews, and based on these high quality systematic reviews, we did evidence synthesize, basically answer what is the benefit, what we can say about the benefit, what we can say about the harms, and also importantly, we did the evidence certainty assessment. And what our conclusion is the evidence on the benefit is very uncertain, and so we there is a good practice to follow to do evidence review. And we believe, regardless of previous position on gender affirming care or the approach, another group could do another systematic review, another umbrella review. But the conclusion, if they are following the good practice methodology process, then the conclusion should be very similar to us.
So I want you to brag for just a second. You were trained by somebody who was seen as the father of evidence-based medicine, and so the criteria you're applying, and all the folks who are applying are standard criteria for evaluating evidence. There's nothing extraordinary about how you evaluate it. The randomized trials are great. Are you rigorously looking at the strength of the evidence? Are you looking at you have systematic ways of evaluating each of these reviews? It's not arbitrary. It's like the way that we normally in medicine aspire to evaluate evidence.
Yes.
Okay.
I do just want to point one very small thing out. Anybody who is serious about evidence-based medicine, who has looked at this question, regardless of where they fall on the question of whether any kids should be getting these treatments, any serious person who looks at the evidence through the lens of these 17 systematic reviews and now our umbrella review will come to the same conclusion, which is that the evidence for benefits is profoundly uncertain, and the evidence for harms is very likely much more certain. And so then the question is what to do with that information. That's, I think, where the debate is and should be. But unfortunately, we still have, especially in the United States, we have medical groups continuing to insist that the evidence is actually very good. So in the United States, we're in this very precarious position, whereas in several European countries, they've already recognized that the evidence is very, very weak.
Okay, so let's talk about the international evidence first, and then actually before the international evidence, I just want to get the sense of the room, because we're talking about pediatric medical transition as a general matter, but there's specific things that people do to patients or to kids, right? And I want to know what the evidence is on that. So for instance, telling a kid that there's something wrong with them, that they need to go to a doctor in the first place. What's the evidence that that's helpful? Is there any evidence on that?
Well, I'm not sure exactly what the question is, but are you saying?
Just let me try to be specific, right? Please. So like a kid is identified by their teacher, or their teacher identifies them as gender confused, gender whatever. There's some process going on, And the teacher then refers them to a psychiatrist, maybe a school counselor or something that then they end up in the healthcare system to begin with. Is there evidence that kind of process of identification helps kids?
Well, I don't think there is. I think you're identifying a problem in the system in that there seems to be a school or other subculture to clinic pathway that really is unnecessary, right? So we've always had gender nonconforming kids. We do need to support and help them as much as possible. They don't need to go to gender clinics, though.
Right, so the question
they don't need to be referred to anyone whose specialty is just gender. If they're having distress or problems, they can go to regular psychotherapists, counselors. They can use the regular tools of support and psychotherapy that counselors are already trained in. In England, we're they're starting to retrain clinicians in this way because they're ahead of us in this process of reform. But no, the idea that they need to go to a gender specialist, I think, is a false premise, and I think is there's no evidence that that's helpful to them. And I think it could be harmful because the whole we're going to immediately affirm your identity is a unproven technique. Well, I can't prove, there's no evidence one way or the other, but that's not generally what we do in psychotherapy. We have kids in development, their identity is constantly changing. We're not trying to have them make lifelong decisions based on what their identity is at age 13. It doesn't make any sense.
Okay, so not very great evidence on that.
Well, I was just going to take it back into the evidence-based medicine terminology realm. So what Ray talked about is the evidence for treatments, and we assess that through systematic reviews. But there are two other aspects that are upstream from that. It's the evidence for diagnosis and the evidence for prognosis. So when you ask what is the evidence that sending a child to a doctor helps, I think upstream from that is the question, how valid is the diagnosis? What does the diagnosis predict? And therefore, what does it say about what's going to happen with the child if you don't treat, and what's going to happen if you do treat? And so if we look at this as evidence for diagnosis, evidence around natural history and prognosis, and evidence for treatment, we now know that we've answered the third question multiple times through 17 systematic reviews. There is no reliable evidence, trustworthy evidence that there are benefits. So now if we go upstream and say, all right, so what is the evidence for the validity of the diagnosis itself? It turns out it's a diagnosis with virtually no predictive validity because a significant proportion of children who will be diagnosed will not have the diagnosis just a few years later. And then the question is, well, what is the evidence around prognosis or natural history? Well, before this model of care became predominant, we had a lot of evidence that children who were presenting with this sort of distress associated with their gender nonconformity would overwhelmingly outgrow it, and a lot of them would become gay and lesbian adults. What we don't know is what's going to happen to the current cohort of kids because it's a very different population. They were not gender nonconforming as children. They were perfectly gender normative, and they only developed this distress for the first time in puberty. We only began to see this phenomenon around 2015, although it started around 2006, but it really became obvious around 2015. Maybe not coincidentally with some other phenomena that occurred in the society with the internet. And we actually, right now, do not know what is going to happen to this cohort of kids that came of age with social media, that developed this very novel presentation, having been gender conforming all their lives, suddenly developing a trans identity and demanding treatment. We do not know what's going to happen to these kids.
Rapid onset gender dysphoria.
That is a four-letter word in gender medicine. There is it's not a diagnosis. ROGD is not a diagnosis, but it is a hypothesized presentation that we have all seen. Some of these young people say they've had these thoughts for a long time and they only told their parents more recently. But if you listen to parental reports that are very convincing, teacher reports, and really, if you're just awake and paying attention in 2025, obviously there is an enormous cohort of kids who were gender normative. Puberty comes around, and around the age 12, 13, 15, 16, a little bit older for boys, younger for girls, they develop a trans identity.
Okay, I'm going to move on. I promise to the medical, the specific medical treatments. I want folks. While you're here on social media, it's a really interesting question. Like, what role has social media played? What is the evidence in this? I mean, there's a graph in the report of this very sharp, almost exponential increase, especially in girls, like teenage girls, receiving this treatment, much more so than boys. And the question is, what role has social media played in that rapid increase versus, medicine itself?
I think I don't mean to be too bellicose about it, but I think you have to have your head buried very deep in the sand to think that there's no relationship between the dawn of the age of social media, the availability of smartphones in the hands of every teenager, the interconnectedness that it promises. We know that there are so the term social contagion, some people are a little off-put by it, but it's a perfectly valid term that's been used for a long time, well before we were talking about gender medicine. Social contagions are real. Teenage girls are very susceptible to them, eating disorders and tics and so forth. And so, right around the time that social media and smartphones become very widely used, especially among teenagers, you see this complete change in both the numbers and the clinical presentation in gender clinics. So in terms of the numbers, pediatric gender medicine used to be a very, very small, it wasn't even medicine, it was just prepubertal children being seen at gender clinics. There were only a handful of these around the world. A tiny, tiny number of them, the vast majority of them would desist and come to terms with their sex. Beginning in the 2010s, you start to see this huge uptick across the industrialized West, not just in the United States. You see 35 to 50x rise in the number of cases presenting to pediatric clinics. You see the number of pediatric clinics themselves skyrocketing from, the first one was established in the United States in 2007. By 2022, there were over 100 of them. And most of the kids being referred to these clinics now are adolescent girls who did not have the history of gender nonconformity before puberty. And most of them have co-occurring mental health problems, depression, anxiety, eating disorders. Autism is very common, highly overrepresented in this cohort, ADHD and so forth. And so that change in the presentation alongside the skyrocketing numbers is what prompted European health authorities to say, wait a second, what's going on here? Let's take another look at this. Let's look at the evidence, let's look at the history. And that's when you start to see this cascade of practice reversals in Europe.
But I just wonder if, we have psychiatrists here, and the question of social media, even for kids who don't have gender issues, that has been the elephant in the room in terms of when gender issues really became pronounced and when social media began to dominate our lives and the impact it had on the kind of the the native generation and how they were growing up. I think psychiatrists here could talk a bit more about what affects social media more generally.
I'll chime in a little. Think about how selfie culture has changed socialization for young females, right? So they're growing up constantly taking pictures. I got two girls that are constantly, they've literally, my daughter just told me, she's now a young adult, she has 14,000 photos on her phone because she was changing the phone. Like, that's how many photos that she has, 14,000. So this is now a really big deal because you're communicating a lot through these pictures to your peer group. And then you throw on that this is a disembodied, different way that people are now sort of living their lives through these, competition with likes and chats. And so social competition and other kind of, so it's only, natural to think that there's some connection between this new, highly technological, disembodied life and people not feeling comfortable with their body. We've really upped the ante, especially for the girls. And it's been, frankly terrible when you look at self-harm, when you look at anxiety, when you look at depression. Those are exactly the groups, and the graphs go up right at 2012 when everyone got on social media, when everyone got a phone, and the transgender identification went up at the same time. So to pull them apart and think that they're not connected, seems nonsensical.
Kathleen, I'd love your thoughts. Also, maybe you could also talk about the report mentions this correlation with autism. Like, there tends to be autism spectrum kids that tend to be pulled into this system in this direction.
Yeah, like Leora was saying, it was the epidemiologic shifts that prompted European health authorities to look closely at the issue, starting with Finland in 2019. And the preponderance of patients with co-occurring autism spectrum disorders, other mental health problems, and the shift from the prepubertal natal males to adolescent teenage girls that was evidenced across all the clinics, was a major factor. But when they started reviewing the evidence in Finland in 2019, there are other reasons for doing that as well. But social media, I don't think I have much to add to what Chris said. The last chapter of the report that's about psychotherapy contextualizes the pediatric gender dysphoria issue within the broader youth mental health crisis that has been widely recognized. Like Chris said, I don't think you can disentangle the two.
Okay, I mean that's depressing given my extensive use of social media. So hopefully it hasn't damaged me too much. But why don't we now turn back to medicine? I'll just list a few things that and I'd love to get the sense of the room on what the evidence says. So the use of puberty blockers to reduce the risk of suicidality and depression in kids that are gender nonconforming, gender have this gender identity issue. What does the evidence say?
There's nothing there, right? There's no evidence that it reduces suicidality or self-harm.
So in other words, the doctor tells a parent that if you don't have puberty blocking, that your kid's going to kill themselves. There's no evidence that suggests that's likely the case.
Correct.
That's right. The evidence that we do have suggests that kids who have gender dysphoria or referred to gender clinics are at elevated risk relative to the general population for suicidality and suicide, actually. However, and this is critical, the risk of of completed suicide is very, very low, continues to be very, very low, thankfully. And what best explains the elevated risk for that tragic outcome are the comorbid conditions that most of these kids present with. That's the conclusion of a study that came out of Finland last year. A very important study because it was the first to actually look at this question.
I do not have much to add to what Chris and Leo have said, but also, like Evgenia said, there is a question of treatment benefit, and there is a question of natural history. So when we evaluate the evidence of treatment effect, we cannot say the evidence support that so-called gender affirming care lower risk of suicidality or suicide. When we are not there to systematically evaluate the evidence on natural history yet, but we do have empirical studies studies from Finland to support maybe the narrative of children will commit suicide if they don't get transition. Maybe the evidence is not supporting that narrative, but we need to evaluate the evidence on prognosis, evidence on natural history.
Just to go back to a point that Ray made earlier, it's of course very easy to bamboozle the public by cherry picking particular low-quality observational studies that purport to show that gender-affirming care reduces suicidality or whatever. And this is very, very common, even in media outlets like the New York Times from time to time.
That's depressing.
And I was only going to point out, and it's not just for puberty blockers, because your question was specific to puberty blockers, but the systematic reviews looked at both puberty blockers and cross-sex hormones, and a lot of debate, for example, in the UK right now, is centering around puberty blockers. But actually, cross-sex hormones are a very powerful drug with irreversible effects, and we need to stop talking just about puberty blockers.
Yeah, I mean, I was going to get to cross-sex hormones, but before we get to cross-sex hormones, I want to just stay on puberty blockers. Let me just throw out a statement I've heard said before, and I'd like to know where the evidence is. The idea is that puberty blockers, a puberty blockade is reversible. That you can stop puberty and then later relaunch it, giving kids time to decide. What's the evidence on that?
Well, so technically, to some extent, it's true that it's reversible. If you were to put a child on a puberty blocker today and stop it next week, you would probably not see much difference in their trajectory. But what the data has shown is that children who are started on puberty blockers are much, much, much more likely to proceed to cross-sex hormones. And if you're working with a rationale, which this field is, that this is medically necessary, another one of these terms that's used in a way that's detached from ordinary standards of reasoning about what's medically necessary, then really there's no way this is going to be reversed because it's medically necessary to continue this treatment. So what the studies have shown is you start puberty blockers, the great majority of children who start on them will end up with cross-sex hormones, and then the effects that those cause.
So I would agree with that, and just add that when we talk about reversibility, so there are the physical and maybe psychosocial, psychosexual development, and whether that's reversible, and then whether the treatment itself becomes iatrogenic and leads to the demand for other treatments that carry much more obvious risks. So I think a lot of puberty blocker reversibility narrative comes from this idea that when puberty blockers were used to stop abnormally early puberty, which is in very, very young children, and then they were stopped, puberty resumed, and long-term outcomes. Actually, there are some concerns about long-term outcomes, but on the balance, it was a beneficial treatment. Puberty blockers used for gender dysphoria are a very different kind of indication. They're being used to stop normally timed puberty. And there are a lot of processes in the human body that we don't fully even understand or what happens during normal puberty. It's certainly not just the development of sexual characteristics. It impacts every aspect of your body. So when they, in the UK, they did research on sheep, and sheep have, apparently, sheep models are very good for hormone research because in terms of being able to then approximate what might happen with humans, better than mice, better than other types of animal models. And in sheep models, when they stopped normally timed puberty in teenage or preteen sheep and then restarted it later, there was evidence that behaviorally the sheep didn't recover. For example, they were taking fewer risks in adolescence, and risk-taking in adolescence is a really important developmental step. So there is evidence from animal models that the effects on the cognition were not, and broadly, different aspects of the brain were not reversed. But it was early research. It was never completed. As far as I know, the researchers still have the tissues in the freezers, and, they saved the tissue in order to study what happens to the brain, and they were not able to get the funding to complete that study. So from animal models, we already have reason to believe that puberty blockers may not be reversible in terms of the psychosocial behavioral effects. But yes, if you stop them after a short period of time, we can expect puberty would resume, but that's not what we're talking about here.
So just to summarize, there's evidence that if you were to stop early, so if you do the puberty blocker, reverse it immediately within a few weeks, you could resume. But there's still some uncertainty about the long-term effects, and certainly long-term puberty blockade, we don't know what the effects are.
Yeah, and you don't get the time back that you would have been developing with your natural hormones. And so this is when they say reversible, it's not like the kids get that time back. They had a period of time when they didn't have hormones, which would have been, engaging in some process. So it's not really reversible. The physiologic effects return once you stop the puberty blockers, but it doesn't reverse anything.
This is where you have to talk about harms of treatment, like the way that the review does, not so much relying on the low quality observational studies that have been looked at in the systematic reviews, but using common knowledge, basic sense, understanding the way that drugs affect the body and that bodies affect drugs, and understanding physiologic, just sexual development. That during puberty, as a physician, that the sex hormones are going to have impacts on synaptic formation and myelination, that they're going to impact bone mineralization in an exponential way. If you give a puberty blocker to a normally developing teenager, 12, 13-year-old, whatever, and they're on the puberty blocker for 4 years, it follows that the bone mineralization is going to fall off, that there going to be potentially a neurocognitive impact because of the normal effect of estrogen or testosterone on the developing brain. And we have, no reliable data for those kids that then start the cross-sex hormone 4 years later. Do they ever make it up? The bone mineral density Z-score, is that ever going to return to what it would have been otherwise? Is the neurocognition affected by that 4-year break, that happened during the teenage years? We have no idea, right? So that's another reason that the reversibility question is a little, it's misleading to use the reversible sort of verbiage, because that really only applies to if you take it away, does natal puberty, resume?
And
yes, but
what Kathleen described is our problems in addition to the fundamental thing that every doctor knows, which is that puberty is the process by which healthy features of being sexed develop. So you develop sexual interest, sexual capacity, and the capacity for reproduction. Mm-hmm. And insofar as puberty is blocked, those ordinary healthy features of being human are themselves blocked.
Okay. Let's turn to cross-sex hormones. So I guess what that means is estrogen and progesterone for boys and testosterone for girls, right? So what's the evidence that once you've hit that once you give that it improves outcomes? Again, broadly speaking, you can choose your own adventure for what improved outcomes means.
Again, same to puberty blockers, the evidence is very uncertain about the benefit of cross-sexual hormones. We cannot say with confidence that cross-sexual hormone will improve outcomes. We cannot say based on our evidence review.
Everyone agree with that? Yeah. Okay. So, I keep thinking back in our heads about the earlier discussion we had of ethics. You have no solid evidence that these extraordinary interventions improve the outcomes, the psychological or other outcomes for these kids. It's not clear that it's reversible if you do it for long enough, and there's certainly a possibility that there's some harm.
Could I talk a little bit more about the harms as well? The bringing in cross-sex hormones to the discussion, we mentioned earlier, in studies, about 95% of patients that are started on puberty blockers will progress to cross-sex hormones immediately. So it really should be thought of as a treatment paradigm, and they're sort of part of the same treatment progression from puberty blockers to cross-sex hormones. And guidelines that are followed in the States do recommend that the puberty blocker be started at the very beginning of puberty. It's Tanner stage 2. So that's going to be as young as 8 in girls, maybe 9 or 10 in boys. If you do start a puberty blocker then, in males, gametes have not developed yet. There's no sperm to do fertility preservation or anything like that if you would for a man going through cancer treatment or whatever. Gametes don't develop for males until Tanner stage 4-ish. This can be like 14, 15. So if you start the puberty blocker at Tanner stage 2 and then you start estrogen 3-4 years later, that male is never going to develop reproductive capacity. Take out fertility counseling, fertility preservation, whatever the case may be, it doesn't matter. They don't have any gametes. They'll never develop them. So infertility is an expected sequela of the treatment. So we can say that that is a well understood harm, and it always has been to the days of the 90s when the Dutch protocol was invented. And that's just one example. There's also issues with stunted genitalia development in males. We'll never develop, adult-sized genitalia that has surgical implications for transgender women. And there's a lot of other sort of well-understood harms of the puberty blocker to cross-sex hormone treatment pathway.
I wonder if I can add something just to illustrate what we're talking about when we're talking about cross-sex hormones. So the Endocrine Society guideline recommends testosterone for girls at 6 to 100 times the normal reference range of testosterone for adolescent females. And just to kind of bring home what that could look like from a clinical perspective, one of the most powerful stories that Jamie Reed, the whistleblower from the St. Louis Pediatric Gender Clinic, she worked there for 4 years, and she saw lots of cases of harms that resulted from the use of cross-sex hormones. And she and her colleague, a nurse, started what they called a red flag list of all these cases. The doctors who were in charge of the clinic basically didn't care. But one of the cases that she described, which was really heartbreaking, was this girl who was put on testosterone. And one of the effects of testosterone in girls is that it leads to thinning of the vaginal walls and atrophy of the vaginal walls. And the girl had sex, and her vaginal wall tore, and she started bleeding so profusely that she called the clinic asking what to do. And the clinic told her, I think it was actually Jamie who told her, put a pad there until it stops bleeding. A few minutes later, she calls back and she said that she had bled through the pad, her jeans, and a towel, and the blood was now soaking through her bed. And so she was rushed to the ER for emergency surgery. So, these hormones are extremely powerful. And at the regimens at which they're given, they can do a lot of damage to the body.
Just want to go back to something we talked about a little while ago about the risk-benefit profile. Ordinarily in medicine, my understanding is that when you're talking about young people, teenagers, adolescents, if you are proposing an intervention that can be expected to lead to infertility, there had better be, right, a proportionate benefit. It is very, very, we take infertility to be very serious generally in medicine. And even if we had good evidence, which we don't, if you look at some of the primary studies, you have a 2-point improvement in depression or so on a 63-point scale. These little improvements, even if we take them at their word that these are solid studies, you have to ask whether a 2-point improvement on a depression scale justifies lifelong infertility. In most areas of medicine, the answer is just obviously not. You'd have to, those sorts of harms are justified to prevent a really bad outcome. Kids who have cancer, say, and they need a treatment that's going to render them, sterile. In those sorts of cases with a grim prognosis, there we can justify the harm because of the proportionate benefit. But in these areas, it's just, even if you accept, again, which you shouldn't, because we have multiple systematic reviews now establishing the evidence for benefit to be extremely weak, but even if we took them at their word, it's not obvious. It's far from obvious, indeed, how we could justify these really serious interventions.
And can I just add that the Endocrine Society makes that explicit. So we have essentially 2 organizations that have produced treatment guidelines. Others are just statements, position statements. But 2 organizations on the basis of whose recommendations all of this area of medicine operates. So, one is WPATH, and that's a subject for another podcast. But and the Endocrine Society is a mainstream, obviously, American Medical Society, even international. And their recommendation for puberty blockers explicitly states, it actually wrestles with the very question you ask about how can we make a recommendation to treat when the evidence is very low certainty. And they're saying in making this recommendation, we are leaning on this values and preferences statement. And this values, which is very important in evidence-based medicine as patient values and preferences. And they're saying in recommending puberty blockers, for example, we put a higher value on achieving a better cosmetic outcome, a hope for that would bring about a psychological outcome. So we put a higher value on achieving a cosmetic outcome than we are, and we put a lower value on avoiding harm from puberty suppression. It's explicitly stated as that weighting mechanism. And that is how it got into medicine, is not on the strength of the evidence, but on the patient value and preference for better cosmetic outcomes.
Can I follow up on that? Because these are kids making these decisions. If it leads to infertility, it's permanent.
Mm-hmm.
Can you have informed consent by kids in that kind of context? I mean, the kids may have strong feelings about this, but ethically speaking, is that possible?
It is doubtful. In my opinion.
When you add to that, also talk about how parents can be proxies for the decision making for kids. They often are, but
sure.
In this context, how
so children have long been recognized as a vulnerable subject group. They don't have power. Their parents have authority over them. They're immature, so they don't have typical understanding. And so generally, except for a few carved out areas, usually by law, children are treated as incapable of granting informed consent to medical interventions. Parents then typically consent to interventions for children. But importantly, it's been long established as a fundamental notion within pediatric ethics that parents, as doctors, as even the state, all must fulfill a fiduciary obligation to children. Parents don't have the freedom to just choose whatever they like. They all must be governed by what the child's medical best interests require. And so that's why we allow state, for example, to come in and take away custody if a parent will not give a child some intervention that's genuinely medically necessary. So the three conditions of informed consent are that you have sufficient information, that you show understanding of it, and that you're genuinely making a voluntary decision. All three of those are highly questionable with respect to these practices.
I want to speak to the sufficient information part. So the scientific community and doctors need to acknowledge that the evidence is uncertain. But what we are seeing in practice is some physicians may be misrepresenting the evidence, saying like, we know it is helpful, we know it is benefiting, but actually we need to recognize the fact that evidence is uncertain.
Okay. One more medical intervention, and then we'll move on to the last stage of our discussion. If you keep going down this line, often the recommendation is if you're a girl, you get double mastectomy. If you're a boy, you get vaginoplasty. It's like you actually end up with permanent surgical intervention. What is the evidence that those permanent surgical interventions improve outcomes like depression, like suicidality, like actual completed suicides?
Again, the evidence is insufficient. The evidence is very weak, not high quality to support that there is a benefit of surgery.
And I think at least one systematic review found that the harms are much more certain.
I mean, those are major surgeries. Like those are not something that you would do on a whim. Right?
So in pediatrics, I would say genital surgeries are uncommon. I do know they're performed, but rarely. But mastectomies are a very, very common intervention for girls. And we have studies published in major medical journals like JAMA that are actually evaluating the outcomes of teenage girls, some as young as 13.
Yeah, the best available evidence on the incidence of mastectomy among minors for this treatment in the United States is that at least, and this is the bare minimum, at least 5,200 girls have undergone double mastectomy. The number is almost certainly significantly higher because that, I won't get into the methodological issues, but we're talking about thousands of girls who have gone through these procedures. Vaginoplasty is significantly more rare. It happens, but it's not a common procedure in minors. It usually happens 18, 19, 20.
Okay, last part of the discussion. We talked about the medical societies, WPATH and the Endocrine Society.
We can't end this discussion without mentioning WPATH because that really is, I think, the source of so many of the problems that we're seeing in this area of medicine. The World Professional Association for Transgender Health is considered the authority in the United States and arguably in other parts of the world for establishing what they call the standards of care, their medical guidelines, medical recommendations. Last year, in the context of a lawsuit being fought out in Alabama over its law that imposes age minimums, the judge in that case authorized subpoenaing of internal communications at WPATH related to how they developed their latest standard of care, which has been widely adopted across U.S. healthcare settings and hospitals and insurance schemes and so forth. And what those documents revealed was, to my mind, smoking gun evidence of a medical scandal. There's really no other way to put it. What happened was that WPATH commissioned systematic reviews of evidence. And then when it found out that the results were likely to be disappointing and would not support its preferred medicalized approach, they suppressed their publication. I mean, that alone should be grounds for, national media attention and the organization doing some kind of, soul searching, if not disbanding. We saw what happened with the American Pain Association, or Pain Society, rather, in the wake of the opioid epidemic. The other thing that WPATH did was it eliminated age minimums, which it had initially proposed for almost all procedures in its guidelines. And then 9 days after publication of Standards of Care in 2022, it issued this erratum and just deleted all of the age minimums. And it turned out from these internal communications, it was discovered that they did so under political pressure from Assistant Secretary for Health Rachel Levin in the Biden administration, and from the American Academy of Pediatrics. They didn't have any scientific or clinical reason to do this. It was a political decision through and through, and WPATH agreed. And then they also failed to manage conflicts of interest among their guideline developers. Basically, they invited to the panel only people who were kind of personally, professionally, and in some cases financially invested in the practice. And they also sprinkled the term medical necessity throughout the guidelines, consciously and deliberately in recognition of the fact that this would ensure insurance coverage for procedures. So this really is, we talk about this extensively in Chapter 10 of the review, but this really is a scandal. And I think the public needs to know about what happened with WPATH.
Let me as a way to sort of stay on the scientific side of this and not move so much on the what should happen in response to the genuinely scandalous things. I want to say fixed on how has the community received your report? I saw that you have an extensive set of peer reviews, and then you have responses to them. What's been the scientific response to the report that as you all written? What kind of critiques do you view as the most reasonable, most interesting, most important to address, and how do you address them?
I'll start, and please jump in. It was very important to us and to the Department of Health and Human Services that this report be put in front of leading authorities on gender medicine who have supported the practice over the years. It was very important to us personally that those who advocate for these treatments and are quoted and cited in the media and so forth, that they look at our work and tell us what we got wrong. And so the Department of Health and Human Services reached out to 3 organizations: the American Academy of Pediatrics, which has been a very strong supporter of these treatments, the Endocrine Society, which produced a guideline and is also a very strong supporter, and the American Psychiatric Association. Unfortunately, the AAP, the American Academy of Pediatrics, initially agreed to review the report, and then at the last minute declined to do so for reasons we're not exactly sure. The Endocrine Society declined from the get-go, and only the American Psychiatric Association submitted a critical assessment. Unfortunately, they missed the entire evidence review. So it's not clear what it is that they were assessing. All the other peer reviewers could easily find it. They overlooked it. They simply didn't find it. And so their criticism was, you never disclosed your methodology, your studies. Here's a list of studies that you should look into. All of those studies were included, or most of them were included. All the ones who weren't included, there was very good reason they weren't included. Regardless, it was unfortunately not a very helpful response. And so what we did, because we wanted to make sure that we're engaging with the best arguments, or I should say the best attempts at rebuttal of the HHS report that appeared in May, we decided on our own volition to respond to 2 published peer-reviewed critiques of the HHS review written by collectively about 24 of the top gender clinicians in the United States. And these articles really try to poke holes in every single aspect of the review. And we respond to them in the peer review supplement, which anybody can find on the HHS website. I don't want people to take our word for it. I want people to actually go and read what are the criticisms of the leading gender clinicians of the HHS report, and what are our responses to those criticisms, and who has the better argument. I mean, this is ultimately a scientific debate.
Just to add to that, you can't say that we dodged our critics. Indeed, we positively sought them out. So we were most anxious to respond to the strongest possible criticisms of the review. And as Leo was saying, you might have expected that the 24 of the top gender clinicians in the country would have been the ones to come up with the most convincing objections. People can read what they say and what we say in response. And the supplement that we produced on November the 19th, when the final version of the review was published, I think that is the go-to document for anyone wanting a relatively brief, I mean, it's clocking in at close to 200 pages, I think, but a relatively brief summary of what's going on and what the major objections are.
And the bottom line is, so there were also reviewers who were more neutral. And by neutral, I mean they're committed to principles of evidence-based medicine. They call balls and strikes. If the evidence is compelling that there's benefits that outweigh the harms, they'll point it out. And they were all very positive about the report. Of course, they had some minor comments of how to make the report better. But they were very positive about it. And that includes, by the way, a former president of the Endocrine Society. And it also includes 2 experts at Belgium's Center for Evidence-Based Medicine who said the umbrella review was very good. So all in all, the peer review process really showed that there were no significant errors in the report or omissions for that matter.
What's the strongest counter-argument you guys saw, and how do you respond to it? If you had to pick one.
So the strongest counter-argument, and actually this is where we're at as a field, because I do genuinely believe, and I think many of us do, that gender clinicians most genuinely want to help these kids, as do we. And actually, we approached this report, and even our critics that we decided to engage with voluntarily, I think we approached their ideas with respect, with the idea that truth emerges through disagreement and debate, and we wanted to debate. And I think that where we're at as a field is, so if I can just kind of give you a 3-point answer. So in general, in medicine, it takes about 17 years to correct. That's kind of a statistic that has existed for a long time. So from 2010 to 2020, as a field, we were in the state of, and it's the greater we, there are disagreements, but if we acknowledge good faith and that everybody actually eventually wants to do the right thing, we as a field between 2010 and 2020 believed that these treatments are beneficial. And that was on the basis of those Dutch studies. And most gender clinicians who entered this field entered on the good faith that those studies actually showed benefits. Unfortunately, they didn't read those studies, but at least they were operating on good faith. In about 2020, we learned that actually that was not the case. Not just the Dutch studies, but none of the studies since the Dutch studies ever showed any credible evidence of benefits. And between 2020 and 2025, pre-HHS report, the field was in a state of acknowledgement of uncertain evidence. Any good faith actor in the field, regardless of how they think to help these kids best, agreed that the evidence for benefits is very uncertain. However, there is also the sense that the evidence of harms is also uncertain. And it is this uncertain balance of benefits and harms that allowed for divergence in approaches of what to do. And what we saw is countries began to diverge for how they deal with this. For example, in the Netherlands, they leaned on the argument of patient autonomy. They said, well, when the balance of benefits and harms and uncertainty, we'll let patients decide, we'll let more mature patients decide. So we assess them for ability to consent, and if they seem mature, minors, they get to consent. In America, the autonomy argument, I think, is less salient because just a different culture. And so here, the medical societies and our critics, I think, are leaning on the argument of, yes, but all medicine operates with uncertainty. This isn't any different. All pediatrics works on low-quality evidence. And I think that is the most important argument for us to come together and debate and discuss. Is it actually true that gender medicine is exactly like any other area of medicine, where it's just uncertain evidence and we should proceed based on clinical judgment? And that is, I think we have a lot to say about that, but that is the strongest counter argument.
Right. So just to follow up on that, so there's, I think in the UK, they are running randomized trials of, I think it's puberty blocking, right?
They just announced it.
Yeah, that's what I just heard. So,
yep.
I mean, that's an attempt to address the lack of certainty and good evidence, right? Is that a reasonable thing to do, or is the HHS support the last word?
So there's going to be a lot of opinions about that trial. There already are a lot of opinions about the trial in the UK and whether it's capable of generating that definitive information that everybody is looking for. It's relatively short-term follow-up. It's just puberty blockers. And we already know that this is not a standalone intervention. Do we want to know if puberty blockers net beneficial or net harmful? Absolutely. But 95% of the kids are going to be getting a combined treatment. So there are a lot of questions about the trial, but I do want to say that what the HHS report brought up as a new chapter in gender medicine is it's the first report to my knowledge. Well, it's actually not the first report because the Swedes did that in 2022, but the HHS report explicitly engaged in the weighing of benefits and harms. And the novel aspect of the HHS report is that it acknowledged that from systematic reviews, the evidence of benefits is uncertain, but so is the evidence of harms. That's also really uncertain, which kind of creates this equivalency. So what the HHS report did is then engaged with other forms of evidence, because in evidence-based medicine, we have to use the best available evidence that doesn't always come from primary studies. So there is knowledge about what blocking, there's knowledge of what hormones do, cross-sex hormones do, there's knowledge of what puberty blockers do.
Biological knowledge.
Biological knowledge. And that biological chapter on what is known was treated by the HHS review as evidence. And once you bring that in, then the balance of benefits and harms does flip. And that is what... but the HHS report wasn't the first one to do that. The Swedish evidence review also concluded that for most adolescents, the harms far outweigh the benefits, which is why Sweden pulled these treatments from from their major public health offering and only administers them on an exception basis now.
Farr, you had a comment.
Yes. Typically, when you're going to develop an innovation, there's a kind of sequence that's followed of, first of all, considering what the biological and other rationale is based on what we know about human physiology, anatomy, et cetera. Then testing it in animals. Then testing it in those who can't, in a limited way, to look for safety, those who are less vulnerable. The problem here is that we have real clarity that there are harmful side effects of these interventions. We don't have clarity that there are benefits that are brought about. And it runs against well-established grain of research ethics that we would take a pool of vulnerable subjects, namely children, and subject them to the known and unknown adverse risks of the intervention before we have a good basis for concluding that this is likely to benefit them in a way that's proportionate to those adverse effects.
So yes, add to what we talk about evidence of benefit and evidence of harms. So what we have done, the overview of systematic review is like we are systematically summarize the evidence at population level or epidemiological level data. But it's in science, it's very common that we consider different lines of evidence. Say, for example, in environmental health regulation or in whether to assess some agent is causing cancer or not, we look at the evidence on at the epidemiological level. And we also look at other parts of science to make a holistic evaluation of the evidence and make decision. And what we can say is like the evidence of benefit is uncertain, evidence of harm is also uncertain, but maybe because of the epidemiology studies, they are not long enough to properly evaluate the harms, or the sample size is not large enough to properly assess that outcome.
I mean, right. That's if you only rely on the epidemiological evidence. But if you rely on the biological reasoning, I mean, there certainly is infertility that happens from some of these treatments, right? There certainly is irreversible surgery, like major surgery. Yeah, there are complications from that. So those, and then of course, there's also the evidence of the fact that there are people who go through this process who then later in life regret having gone through this process, the detransitioners, right? So all of that seems like it's clear evidence of potential harm.
And sorry, if we also go back to the question about doing a trial, and the condition of doing a trial is equipoise. And so the HHS report did argue about what is the benefit of evidence, what is the evidence of benefit and what is the potential, based on what we already know about biology, pharmacology, and mechanism, what are the potential harms. So then when we decide whether it is ethical to do a trial, we need to consider this knowledge.
I also should step back and just think about, I mean, I started medical school in 1995, and for over 20 years, I mean, and I was busy. I saw a lot of patients. I never saw a single child expressing gender distress and wanting to transition for over 20 years in medicine. So now, I've had clinics where I've had 3 kids with a gender dysphoria diagnosis in my resident clinic in one afternoon. That's not what it usually is, but occasionally that happens. So we also have to step back, and this whole phenomenon is a very new thing that we need to put in context of what is going on in our society and wider issues. And so we should be cautious for anything that is this new and has changed this fast, especially knowing the demographics changing and all the comorbidities and all the problems. So I think whenever we're talking about doing trials or thinking about this, we need to step back and think about the larger context.
Okay, last question, I promise, but I think this is going to be very, very, very important for American parents and families to hear the answer to this question. What should they do with their kids that are going through this process? I mean, you all have now are the experts in evaluating scientific evidence. You've thought through the ethics. You've thought through the so many of these issues. What advice do you give to American parents who have a child that's going through this? How should they interact with the medical care system? How should they protect their kids and do the best by their kids?
I am a philosopher, so I would like to defer to the people who are proper doctors.
Alex, this is, as we've seen, it's more than just philosophy, right? So I think it's a legit
I'm not in the business of advising parents.
Well, as one
Kathleen or Farr,
one physician, I would say the first thing we do is do no harm. So I think I would tell any parent, resist the inducement to medicalize this problem. Objectively, there is nothing wrong with your child's bodily health. That's a standard that physicians have hewed to for good reason. And when they get away from it, they've done harm historically. And I think we're doing harm in this case. So it's hard. It's a struggle. Be patient. But one thing I would encourage them to take off the table for now is medicalizing this and blocking healthy development.
I would be very wary of people that express great certainty if a parent is taking a kid to see a professional, especially if they hear a statement like, you can either have a trans child or a dead child. Things that evoke a huge amount of certainty, I would be very cautious.
Yeah, and I don't think there's going to be a one-size-fits-all because all kids are different. And so each kid deserves an individualized assessment. We need to look at what's going on in their life. Often in therapy, there's what's going on, and then there's what's really going on, and was there trauma? Are they, feeling like they're not succeeding as a boy or a girl? Is there some kind of social benefit? So transgender identification is now a youth subculture, and it's not necessarily if there wasn't medicalization or other things that, if it wasn't leading on a pathway or leading kids to be distressed, it really wouldn't be a big deal. We wouldn't be talking about it. We don't need to medicalize a youth subculture. So people need to contextualize it properly as there's no rush. There's not a hurry. Let kids grow up, support them. Probably a lot of these kids in distress are not having their needs met. And in some ways, maybe we're failing as a society to really take care of our kids in the right kind of way. And I think, Jonathan Haidt has made some really nice suggestions about, getting kids into the real world, trying to get them off of technology, helping them, develop into robust, strong people, taking more risks as a kid, putting them in situations where they're on their own and are not hovered over or, overly constricted by adults. I mean, there's all sorts of suggestions that you could have, but I think you can't make a overall, we're going to do this or that because every kid is different.
So I made a short list, which will probably take an hour to get through. So I'll try to, I would say as a parent, there are some things parents should not do. I think parents, first of all, I want to say parents are in a terrible situation. We have created a system where children are actively encouraged to interpret their adolescent distress through the lens of transgender identities. They are not given other frameworks to think about. Everything is refracting through this lens at the moment. So and schools are encouraged to keep that secret from parents. So by the time a parent discovers their child is trans-identified, the child has already made plans for testosterone and a mastectomy. And that becomes a very entrenched belief. Children often begin to decompensate, and from happy children, they become quite distressed. Some could actually attempt suicide. There's not, parents who are in that situation are not currently being supported by the medical community. The medical community has let them down. If such a parent takes their child to a pediatrician is most likely to defer to a specialist. Not unlike if you take your child with a complex fracture to a pediatrician, they're going to say, oh, this is for an orthopedist. This isn't for me. And sends the child to an orthopedic surgeon. A pediatrician is very likely to do two things. First, they're going to restate what the American Academy of Pediatrics says, which is this is a very healthy and normal thing, and your child might just be transgender, but they also might not be. And there's a specialist who can tell that apart. They are at a local gender clinic and write a referral. A hopeful parent then takes that and thinks, well, for sure they're going to, if this is one of those rare cases of having a transgender child, they'll tell me, but probably not, so they'll just help me. What the parents don't realize, and actually what the pediatrician doesn't realize, is that the referral to a gender clinic is a referral to hormones, and if you're a girl, mastectomy. The gender clinic staff overwhelmingly treats every incoming patient as a transgender patient, and therefore sees them as a candidate for transition. And as we have learned from some of the major NIH-funded studies, that gender clinics, American gender clinics, will proudly say that every child who considers themselves transgender and wants to transition will transition, that it's extremely rare to find an adolescent not being capable of consent. Even co-occurring mental illness is not a barrier. And so essentially, a referral to a gender clinic is a referral to transition, and transition is associated with a honeymoon period. So no, these children aren't going to say they regret it. In fact, girls on testosterone could report being a lot more energized and happy. So there is no good answer for parents right now. And I think we urgently need to make sure parents are aware that their doctors are behind the curve on science, that the parents, I suspect the parents will realize this before medical societies, and a lot of us parents know we need to challenge physicians on all fronts. And it's time for parents to start asking tougher questions. And I think your job, frankly, the NIH job, is to start funding research into actually how to help these kids.
Can I just add one thing to that? So chapter 11, appropriately numbered, of our report gives quite a lot of evidence for what Evgenia is talking about, this kind of pipeline with no safeguards, no checks, nothing. As soon as the kid enters the gender clinic, the treatment decisions are based on what the kid wants. And parents who resist, gender clinics are very capable of knowing how to twist their arms. In some states, they do that by threatening child protective services. In some cases, they'll say this, they work with the parents, which means pressure them to give them the dead kid threat and all that kind of stuff. So we walk through evidence from their own mouths. They themselves say that this is what they do. And in fact, the author of the American Academy of Pediatrics policy statement, Dr. Jason Rafferty, he said in an interview in 2023, in response to the question, what is gender-affirming care? He said that treatment decisions are oriented around a child's sense of reality. I mean, this is how they explain what they do. This is not our interpretation or our spin on it. This is what they say. And part of the reason is because they are committed to the proposition that being transgender is normal and healthy, natural variation of human existence, and that to question it or to see it as something abnormal or anything pathological is evil and wrong, and it must not be done. And so what these kids don't get is proper exploratory therapy to try to figure out, why are they rejecting their sex? Why are they feeling so uncomfortable going through puberty? Why do they feel like they need to inject their bodies with hormones or undergo surgeries? And so I'm not a doctor, but I do constantly get questions from parents who will reach out to me and say, what should I do? And so my advice, number one advice, just like Evgenia says, is avoid gender clinics at all costs, because that is a guarantee that the kid will get whatever they want. And that what you should do sooner rather than later is find a therapist who is a non-affirming therapist. Now, that might sound weird, but what that just means is a therapist who is not kind of pre-committed for ideological reasons to agree with how the child self-diagnoses and go along with that self-diagnosis. Meaning, they need to find a therapist, somebody like Chris, somebody like Kathleen, although I don't think you work with kids, but somebody who is committed to the classic approach of psychotherapy to try to understand what is making this kid distressed and how can I help him.
Well, thank you so much for this really incredible discussion. I've learned a ton. I hope the listeners have learned too. Thank you for listening to this very special edition of Director's Desk. I strongly encourage those who are listening to go look at the HHS report. It has a lot of what we talked about and more, as well as a tremendous number of footnotes if you're willing to dig into it. Thank you for joining me today on today's Director's Desk. To listeners, thank you for tuning in. Drop your comments in the chat as to the subjects we should cover in future podcasts, and be sure to hit that like and subscribe buttons on your preferred podcast. Until next time, I'm Dr. J. Bhattacharya, and this has been the Director's Desk.